Okay, so let's talk about kidney today. For the location of the kidney, it's located between the T12 to L3 vertebra. Okay, the T12 to L3 vertebra, kidney is located between them. It's the same location as of the pancreas, right? So the average weight of the kidney in males is 150 grams, and in females, if we talk about, it's 135 grams, right? So if we talk about now the length of the kidney, it's 11 centimeter long, 6 centimeter wide, and 3 centimeter in thickness. So 11 centimeter in length, 6 centimeter wide, and 3 centimeter thick, right? Now to talk of the exact location of the kidney and the distance of the upper pole and the lower pole, we have something known as the Morris parallelogram. Now what does this parallelogram tell us? It tells us that if you draw a vertical line from the spinous process of T11 vertebra to the spinous process of L3 vertebra, right? So here is this vertical line, and 2.5 centimeter from this vertical line you draw another plane, and 9 centimeter you draw another plane. So the kidney will be located in this area. The right kidney and the left kidney both will be located between these two vertical lines, 2.5 centimeter and 9 centimeter. In this area the kidneys will be located. Now of course the right kidney will be lower than the left kidney. Why? Because on the upper side, on the superior side, you have the big liver. Okay, so this we've talked about the exact location of the kidney. Now let's move to the external features. Now for the kidney you have two poles, two surfaces, some borders, and hilum. So the two poles will be obviously an upper pole and the lower pole. Now the characteristic is that the upper pole is thick and rounded. Why? Because the suprarenal gland sits on the upper pole, so it has to be thick and rounded to support the suprarenal gland, and the lower pole is thin and edgy. Okay. Now if we talk about the hilum, in the hilar relations we study something known as the VAP, from anterior to posterior. In most of the places, as from on the subcostal area too, we have studied the VAN relation, vein, artery, and nerve. But here's the VAP relation. What's that? From anterior to posterior, if we go, the V stands for renal vein, A is for the renal artery, and P is for the renal pelvis. Okay, so VAP relation. And sometimes there is a subsidiary branch of renal artery. Okay, arising from the renal artery, there is a subsidiary branch. So this may or may not be present. So if the subsidiary branch is present, what's the posterior most structure? It's the subsidiary branch only and not the renal pelvis. Okay, but normally it's not present, it may be present. So remember this VAP relation for the hilar relations: renal vein, renal artery, and renal pelvis, right? Okay. Now to talk about the relations of the kidney, let's first talk about the anterior relations. The anterior relations are very easy. We have the right kidney here and the left kidney here. In now some features will be common in both the kidneys. And what will be they? The suprarenal gland will be common in both, sitting on the top. Okay. The jejunal flexure will be common in both. Okay. Now what lies on the right side? You have the liver, so obviously there will be a hepatic impression, and colon is passing like this, and there here we have the colic impression. Same transverse colon will be passing, so again you will have the colic impression. And above that lies the pancreas, and on top of that you have the gastric impression for the stomach, and along with that you have the spleen, right? Now why I have highlighted these structures like the hepatic impression, the jejunal impression, the splenic impression, and the gastric impression? The significance is that these parts are covered by peritoneum. These are the peritoneal parts. If you look at this diagram here, this part, the hepatic part, the colic part, the jejunal part, sorry, here also the jejunum, stomach, and the spleen, these are covered by peritoneum, right? So kidney is not basically peritoneal, it's retroperitoneal here. Okay. And in this diagram also you can clearly see the anterior relations. Here you have the suprarenal area, the duodenal area of the duodenum, a large hepatic area of the liver, the colic area of the transverse colon, and the jejunal area. And on the left side You have the gastric area, along with that the splenic area. Below that you have the pancreatic area, the colic area, and the jejunal area. And here you have the both ureters, right? Okay. Now to talk about the posterior relations, they are very easy. First, let's talk about this major thing here, guys. The 11th and 12th rib are in relation with the posterior relation of the kidney. But remember, as the right kidney is lower than the left kidney, the 11th rib is not in relation to the right kidney. Why? Because it is lower. Okay. So on the posterior side, you have the 11th and 12th rib in case of the left kidney, and only the 12th rib in case of right kidney. Rest all of them will be common. And what are they? So you have the lateral arcuate ligament of the diaphragm. This is the diaphragm here. You have the lateral arcuate ligament. On the medial side, you have what? Medial arcuate ligament, obviously. The three muscles from medial to lateral side, if we go, what are they? The psoas major, the quadratus lumborum, and the transverse abdominis. The three major muscles from medial to lateral side, if you move, you have the psoas major, the quadratus lumborum, and the transverse abdominis. Right. Now some nerves and vessels. The 12th rib will be lying here. So what will be present here? Below that, the van relation of the subcostal nerves and vessels. So here you have the subcostal vein, the subcostal artery, and the subcostal nerve. VAN, right? From superior to inferior side. And you have the two nerves here, the iliohypogastric from the L1 and the ilioinguinal from the L1 as well, coming from the lumbar plexus. Okay. Now if you look at this diagram here you have the right kidney and the left kidney. Here you can clearly see this is the 11th rib, and it is not in relation with the right kidney but in posterior relation of the left kidney. Okay. And again you have the diaphragm here. Here will be the median arcuate ligament, the lateral arcuate ligament, the psoas major muscle, then the quadratus lumborum, and then the transverse abdominis, right? Okay, so this diagram you can draw for the theory examinations. All right, here will be passing the iliohypogastric and the ilioinguinal, and here will be the T12 and the subcostal nerves and vessels, basically, right? Here again you can see the posterior relations, the diaphragm. Here is the 12th rib. These are the subcostal nerves and vessels, vein, artery, and nerve, the transverse abdominis, the quadratus lumborum, and the psoas major muscle. Okay. And here you have the two ligaments of the diaphragm, the medial arcuate and the lateral arcuate. Please don't confuse this medial arcuate with median arcuate. Okay, they are not the same. Now let's talk about a high yield section here, that is the covering of kidney. Now kidney basically has four coverings. Let's study about them one by one. First is the renal capsule covering the kidney. It's the true capsule. So this is the kidney, here will be the renal capsule, right? Outside that will lie the perinephric fat. Okay, this you can see, this all is perinephric fat. And if the perinephric fat is too less, there will be a pathology known as floating kidney, right? Because the kidney will not be fixed in its place by these fat lobules. Next you have the renal fascia, which is also known as the fascia of Zerota. Now it's a false capsule. The renal capsule was a true capsule, but the fascia of Zerota is a false capsule. And the outermost layer is the paranephric fat, which is present more at the lower pole because it has to fill the paravertebral gutter on the inferior side and provide cushioning to the kidney, right? Now let's study about this renal fascia in detail. Okay. Alright, so I've taken this another section here of the renal fascia of the kidney basically, and here we'll study about the two layers of renal fascia. So we have one anterior layer and one posterior layer. The anterior layer is called the fascia of Tolt, and the posterior layer is known as the fascia of Zucker-Kandel. Okay, and as you can see on the superior side, these are attached to the phrenic fascia, that is the fascia of diaphragm, but on the inferior side it is open, right? Okay, and here you have the suprarenal gland. This is the kidney, of course, the anterior layer, fascia, the fascia of Tolt, and the posterior layer, the fascia of Zucker-Kandel. Now the posterior layer inferiorly fuses with the fascia laica, which later forms the posterior layer of femoral sheath, and the anterior layer fuses with the extraperitoneal connective tissue. Okay. Now in this diagram I've taken another section here. It's from the BDC. Here you can clearly see this dot or this whole of the fascia represents the anterior layer of the renal fascia. This thing right here represents the posterior layer, and here you have a connective tissue septum. What's that? That is connecting the anterior layer with the posterior layer, right? So the connective tissue septum connects the anterior and the posterior layer. Now what's the function of this? If ever there is a perinephric effusion, okay, so it prevents the perinephric effusion to travel medially to the other side of the kidney, right? Because this basically closes this gap here. Here this gap is closed, here this gap is closed. Superiorly they are attached to the phrenic fascia. Okay, superiorly they are attached to the phrenic fascia though, so it can't go up. Now where the perinephric effusion will go, only one way is left, that is inferiorly. Okay, so if ever there is perinephric effusion, it will go inferiorly, right? So according to the old concept, they fuse and form the fascia transversalis, but there is also a new concept that we won't study in this lecture, and the anterior layer continues, right? And again here you can see the kidney, the suprarenal gland, and the renal veins and vessels. Okay, here's the inferior mesenteric artery. All right, here you can also see the arteries supplying the suprarenal gland. Okay, what are they? The superior suprarenal arteries, these ones, the middle suprarenal arteries, these ones coming directly from the abdominal aorta, and the inferior suprarenal arteries, this which is coming from the renal artery itself. Okay, from where the superior renal suprarenal artery is coming, from the inferior phrenic artery. Okay, now let's study the arterial supply of the kidney. First let's discuss these vascular renal segments. So you have 5 vascular renal segments anteriorly and posteriorly total. Okay, so the upper segment near the upper pole, it's a superior segment. Near the lower pole you have the inferior segment, and between that you have one anterior superior and anterior inferior segment. This is the anterior superior, this is the anterior inferior segment, and on the posterior side you have just the posterior segment. The superior segment will be same and the inferior will be same. All right, it will also reflect basically to the posterior side. If I flip this kidney here, okay, so then you can see the relations. And here also the same. On anterior side we have the apical segment, the superior, the upper segment, that is the anterior superior segment, the middle segment anterior inferior, and the lower or the inferior segment, basically this one. Okay, and on the posterior division you just have a posterior segment. So the renal artery basically divides into 5. All right, but you have to keep a major thing in mind. If I draw a line here which separates the upper and the middle segment from the posterior segment, this is an avascular plane, guys, and it's known as the Broddel's line. So whenever a surgeon has to give a surgical incision, they prefer to give an incision on the Broddel's line. Why? Because there is less chance of bleeding. Okay, and it's present on the posterior surface at the junction of medial 2/3 and posterior 1/3. Okay, the junction of medial 2/3 and posterior 1/3 segments, right? And in this diagram you can see how the renal artery divides. Basically here you have the renal artery. It divides into various segmental arteries depending on the 5 segments we have studied. Okay, so here is the posterior segmental artery, posterior branch of renal artery, or the posterior segmental. And on the anterior side you have the 4 segmental arteries. What are they? The apical segmental artery, the anterior superior segmental artery, the anterior inferior segmental artery, and the inferior segmental artery. And further it divides into interlobar arteries, which further divide into arcuate arteries, which further divide into interlobular arteries and supply the substance of the kidney. Right? We'll take up this in more detail in some while. Okay. So yeah, this is the route. From the abdominal aorta at the L2 level, you have the renal artery. It gives off 5 segmental arteries, 4 anteriorly and 1 posteriorly. Each segmental artery forms the lobar artery. The lobar artery then forms the interlobar artery. The interlobar artery then forms the arcuate artery. The arcuate artery divides to form the interlobular arteries. The interlobular, here it was the interlobar, but here you have the interlobular, between the lobules. The interlobular artery continues to form the efferent arteriole, then the tuft of glomerulus, then the efferent arteriole, and from the efferent arteriole forms the peritubular plexus, and then you have the corresponding veins. So the interlobular vein, the arcuate vein, the interlobar vein, the lobar vein, the segmental vein, the 5 segmentals vein, which merge and drain into the renal vein, and the renal vein finally drains into the IVC, inferior vena cava. Okay, so now we have majorly done with the chapter. Now let's study about the lymphatic drainage of the kidney. Now the lymphatics of the kidney drain into the lateral aortic nodes located at the level of renal artery, that is the L2 level. Where they drain the lymphatics, they drain into the lateral aortic nodes located at the L2 level. And for the nerve supply, parasympathetic, the same loyal nerve, vagus nerve, and for the sympathetic, it's T10 to L1. The nerve supply is T10 to L1. Okay, now let's come to the applied anatomy. But first, let's study some peripheral points here. So in a fetus, the kidney basically develops, and how it develops, it's lobulated. The kidney is lobulated and made up of 12 lobules. But after the birth, the lobules gradually fuse to form a single kidney. Okay. Now you have something known as the renal sinus. What's a renal sinus? Here in the dissection picture, you can see this circle, or this space is known as the renal sinus. What the renal sinus has? It chiefly has the branches of the renal artery and the tributaries of renal vein. Remember, artery has branches and vein has tributaries. Okay. Next we have the renal pelvis. The pelvis divides into the major calyces. The major calyces then divide into the minor calyces, and minor calyces ends into renal papillae. Okay. Let's see in this diagram here. Here you have the cortex, the pyramid of renal medulla, this pyramid right here, the renal medulla, the cortical lobule, the renal column. What's renal column? It's basically the part of cortex that extends between the pyramids of medulla. Okay, here you have the arcuate artery and vein, which we studied, which gives off branches, which branches the interlobular, which supply the substance. Here you have the interlobular artery and vein, these minor arteries and veins which you can see. You have the interlobar artery and vein, the renal artery and vein. Here you have the renal pelvis. Okay, divides into the major calyces, then to minor calyces. This is the major calyx here, this one, and this is the minor calyx. Okay, and it's a lobe of kidney, this whole portion. So like 1 lobe, 2 lobe, 3 lobe, like this. Right, now for the nephron, you have the glomerulus. First you have the efferent arteriole. From the tuft of capillaries in the glomerulus, this is the Bowman's capsule. Then the efferent arteriole. Okay, from the Bowman's capsule you have the PCT, then the descending loop of Henle, ascending loop of Henle. Okay, and from there you have the distal convoluted tubule, the DCT, and then a junctional tubule which forms a junction between the collecting tubule and the DCT. This portion right here. Okay, so we majorly done. The last thing left is the juxtaglomerular apparatus. What's this? It's formed by 3 major things. The macula densa, which is the modified cells of the DCT. Here you have the DCT and the modified cells. These cells which you can see, they are the macula densa. The juxtaglomerular cells, which are the epithelioid cells in the media of efferent arteriole. Here you have the efferent arteriole, and these epithelial cells which get modified, they are known as the juxtaglomerular cells or the JG cells. And finally you have some A granular cells between the macula densa and what, the juxtaglomerular cells or the glomerulus proper. Okay, so these cells which you can see filling up this space, that is the A granular cells. So these three things form the juxtaglomerular apparatus. All right, so now let's talk about the applied anatomy here. The first point we have is that if there is an apparent renal artery present, it's present in 30% of the population, quite famous here, and it's a direct branch from aorta to the lower pole of the kidney. Next, we have the polycystic kidney disease, PKD. It's a congenital disease in which cysts develop on the surface of kidney, as you can well appreciate in this diagram as well, and it can lead to renal hypertension and renal failure ultimately. Next, we have something known as the horseshoe kidney. What's a horseshoe kidney? As you can see, doesn't this shape look like a horseshoe to you? Right? Now what's the anomaly here? Basically the lower poles haven't separated from each other. And as we know, while the kidney is developing, it tends to rotate inward and ascend upward. But remember, what is this artery here? What's this artery? It's the inferior mesenteric artery. Now, can the kidney descend upwards? No. Why? Because this artery lies in path of it. So it can't rotate, it can't descend. That's why the ureters, as you can see, lie in front. Normally they are present at the back, but now they lie in the front. Why? Because it can't rotate inward and can't ascend. Okay. So we're done with this. We're done with the arterial supply. Now, yes, one thing was left here, that if you try to approach the kidney from the posterior abdominal wall, which structures you will encounter. Now, suppose if I'm trying to reach to the kidney from the posterior abdominal wall, which structures I'll encounter? Now, obviously, the first structure I'll encounter is the integument or the skin. Below the skin, where you have the superficial fascia, right? So the skin, the superficial fascia. Now the third thing you will encounter is the posterior layer of thoracolumbar fascia, and along with this there will be two muscles present, the latissimus dorsi muscle and the serratus posterior inferior. Okay, now as you approach the posterior layer of thoracolumbar fascia, you'll also encounter two muscles, latissimus dorsi and serratus posterior inferior. Okay, now next, if you have crossed the posterior layer of thoracolumbar fascia, you'll have a major muscle which lies between the posterior layer and the middle layer, which is the erector spinae muscle. Now, as you've crossed the erector spinae, then you'll have the middle layer. If you've crossed the middle layer, then you'll again encounter a muscle. Which muscle? Quadratus lumborum. Now, after that, it will be the last layer, that is the anterior layer of thoracolumbar fascia. Okay, so basically, you will encounter 7 structures. First is the skin, then the superficial fascia, then the posterior layer of thoracolumbar fascia along with those two muscles, the latissimus dorsi plus the which muscle? Serratus posterior inferior. Serratus posterior inferior and the latissimus dorsi. After that, well, what will you find? The erector spinae muscle, then the middle layer, then again a muscle, quadratus lumborum, and then finally anterior layer of thoracolumbar fascia, and then you'll finally approach the kidney. Okay. Now again, talking of some clinical aspects here. Now during the surgical procedures, you have to keep in mind that when approaching the kidney, sometimes the 12th rib is removed. Now what if the lower border of the pleura lies in between the 12th rib? This you have to keep in mind. Now when the 12th rib is absent or too short, the 11th rib is confused for the 12th rib. And if the 11th rib is removed, you're opening the pleural cavity. Okay, the pleural fluid will leak out. So this has to be kept in mind. Okay. And here you have the 12th rib, and here you can see a renal angle. What's this renal angle? What's this muscle right here? The erector spinae muscle. And here is the lateral border of erector spinae. The renal angle is between the 12th rib and the lateral border of erector spinae muscle. This angle is the renal angle. And tenderness in the kidney is elicited by applying pressure over this angle with the thumb. Okay, so the tenderness can be drawn out if you apply pressure at the renal angle. How the kidney is palpated? It's palpated bimanually, which means by the use of 2 hands. Now when the kidney is enlarged, in case of renal megaly, the lower pole of kidney becomes palpable on deep inspiration. Remember, on deep inspiration, the lower pole of the kidney becomes palpable. Right? Now kidney is prone to have stones, which are known as stag stones, and urine gets collected here. Okay, so it basically has to deal with large amounts of urine, and sometimes kidney can develop stag stones. These are very different from gallstones, as the kidney stones, stag stones, lie on the body of the vertebra itself, but the gallstones lie anterior to the body of vertebra. In this diagram, you can see here you have the renal stone on the body of the vertebra, but the gallstones lie anterior to the body of vertebra. Okay, in this X-ray diagram you can see the stag stones, the staghorn stones basically in the kidney. Okay, these large stones, these all are staghorn stones. So we're done with kidney here. Let me see if anything is left. Mostly we have covered everything. Remember this Brodels line, a major clinical aspect, and these anterior and posterior relations of the kidney too. Maybe a diagram based question can be asked sometimes. And yeah, so we're done with the chapter. Thank you very much.